Danella is a physiotherapist that's currently working with the osteoarthritic chronic care program, and she's worked in the orthopaedics area at Fairfield Hospital since 2008 and has been working as the musculoskeletal coordinator since October of 2009. Today Danella is presenting for us on the Fairfield site osteoarthritis chronic care program, improved program outcomes attributable to embedding health change, patient-centred behaviour change methodology. Thank you.
Thank you, Kylie. So good afternoon, everyone, and thank you to everyone who stayed around for the presentation. I'd like to thank ADMA for having us present here today. I've done this presentation today with Jeanette Gale, who's the health psychologist and CEO of Health Change Australia. And I'm looking forward to presenting today on how we've embedded the health change patient-centred behaviour change methodology into our program at Fairfield Hospital. I'd like to thank Jeanette for the opportunity to be able to collaborate on today's presentation. I'd also like to acknowledge and thank the Agency for Clinical Innovation Musculoskeletal Network for the collaboration we've had around the osteoarthritis chronic care program, as well as the colleagues that I work with at Fairfield Hospital with the Whitlam Joint Replacement Centre, the Whitlam Orthopaedic Research Centre based at Liverpool Hospital, and the staff I work with in South West Sydney Local Health District. So I'm going to touch on the health change methodology briefly with a slide that Jeanette's kindly put together. And then I'm going to talk to you about the osteoarthritis chronic care program that we have at Fairfield and how it's changed with implementation of the principles that I'm outlining in the next slide. Then touch on some of the observations that have been made with implementation of patient-centred behaviour change methodology. So health change model of behaviour change that is about integrating patient-centred communication and behaviour change support into a clinical practice decision framework to increase adherence to evidence-based treatments and health recommendations and or quality of life goals. So this is some of the suite of clinical tools that are available to clinicians, and Health Change actually has a site here as well, so feel free to go and have a talk to Jeanette and her team out there about the suite of things that you can look at for clinicians to operationalise things. So at Fairfield Hospital, the osteoarthritis chronic care program has been running at Fairfield since the end of 2010. And prior to this, a similar program was running, and staff at Fairfield worked with the ACI to develop the osteoarthritis chronic care program model of care. At Fairfield, clients who participate in the OACCP are those that are waitlisted for primary elective joint replacement of either their hip or their knee. Prior to October 2011, the program comprised of an initial assessment with a group education session which focused around conservative management options that people should be undertaking to help them to manage their osteoarthritis. The clients then sat one-to-one with the nurse and physiotherapist and completed an initial assessment around their medical history and what their management needs were. They had goals developed and they continued to work on these whilst they were awaiting surgery, and they had subsequent follow-up 3 and 6 months after that initial appointment. The osteoarthritis chronic care program has a strong focus on holistic, client-centred care, and staff are encouraged to attend the Health Change Australia training. Both physiotherapy staff and the orthopaedic clinical nurse consultant at Fairfield Hospital participated in the Health Change Australia training initially in 2011, and then we completed the follow one-day workshop in 2012, mid-2012. Following this, the patient education format was changed to provide information about what self-management actually involves, such as the process of goal setting and making an action plan and the expectations around this. Clients were then provided with a menu of options whereby they were presented with different conservative strategies for osteoarthritis and chronic disease management at large. This is now subsequently addressed further in the one-to-one session with either the physiotherapist or the nurse. And it was at that point in time that we identified our roles were interchangeable in that sense, and we could work on the strengths that each of the different clinicians provided. And following the second health change workshop that we did, we implemented phone support, which allowed us to assist in addressing barriers to the change process earlier, rather than getting to that 3 and 6 month face-to-face review that we're having with the clients. So how are the principles being implemented? Well, client-centred, what does that really mean? Following the health change principles and methodology, it's about giving clients choice and control. It's about first asking a client about solutions and then offering them suggestions. It's waiting till late, so it's giving them people time to come up with their own strategies for change, and it's about providing targeted education and individual goals. So if we touch on each of these areas separately, clinicians tend to feel their role is to assess and give people strategies to assist with management in line with a goal. We're the expert in this problem, that is why they've come to us for a solution to help them to fix the problem. Although this approach does seem client-centred, because it is about the client, it's actually a passive process over which the client actually doesn't have much control. Previously, we'd do all the talking, but using the principles of first ask, then offer again allows the client to be in control of obtaining the information, and most of the time they'll want your strategies, but importantly, they've made the choice to do so. Previously, I would think when you asked someone a question, no response means they need your answer and they need the solution. However, the client needs time to digest information, gather thoughts and plan, and this gives them the opportunity to do so. Prior to completing the Health Change Australia workshop, we would complete an education session, as I mentioned previously, with clients, informing them of different conservative options, such as exercise and weight loss as examples. We now provide a more targeted education session with a strong focus on the client being the expert in their own health, and health practitioners act as facilitators. By doing this, the client then has the choice and they're in control. So in addition to the principles I've discussed so far, the health change methodology enables clinicians to have a framework, and by having this framework allows you to identify what stage of the decision process of lifestyle, clinical or medical change a client is at. This approach can be highlighted in a case study of a gentleman that I've seen. He had multiple comorbidities, including neurological problems, morbid obesity, diabetes and hypertension, on top of his knee osteoarthritis, of which he was awaiting joint replacement for. Functionally, he had poor mobility. And through using this systematic approach, I'd identified he was not at the stage where he was ready to make change, and he didn't want to listen to anyone about that either. Key to our initial conversation was that he told me that the only person he would listen to was his army sergeant. It was at this point that I could target our session more appropriately for this patient. I'd identified his motivation. I acknowledged at that time point that he wasn't ready to make change, and in this instance, I called it as I saw it. It's important, however, that this is done with tact. It should not be abrupt. Therefore, in this scenario, with appropriate sensitivity to the gentleman's situation, I provided him with some more insight into his health through decisional balance technique, which is another technique we've learnt through the health change training. The plan from then was allowing him to do all the talking with that decisional balance technique, and we had further phone and face-to-face contact when he was identified that he was ready to work on an aspect of his health. So overall, the client has changed from someone who was disconnected with health, given the numerous appointments that he had for the numerous problems that he had, to now being connected and quite proactive in the coordination of his care. And he's the one that now calls us to let us know when his next appointment it is in regards to his fitness for surgery. So what are some of the observations that have been made with the OACCP across New South Wales? I'd just like to acknowledge Mary Feen, who is the project officer with the Musculoskeletal Network, working on the OACCP. She's given me the information that I'm presenting now. So there currently is 10 local health districts, inclusive of 18 hospitals across New South Wales, whom have implemented the OACCP. And what we've seen is that 80% of people have achieved a weight reduction, with 14% of people losing more than 5% of body weight at their 6-month review, which we've seen in some various talks throughout the conference is quite significant. 1 in 3 people treated with knee osteoarthritis are improving their 6-minute walk distance by more than 20% at their 6-month review appointment. And the number of people at risk of falls has decreased from 40% down to 34% by their 6-month review appointment. And that's when we look at a functional measure called the timed up and go, which is an indicator of falls risks. If we now have a look at what we've seen locally at Fairfield, clients awaiting joint replacement are now proactively involved in their ongoing health and care, where previously they would be waitlisted for surgery and not see another clinician until just prior to surgery. At this point, they'd undergo routine preoperative tests, see the registrar and see an anaesthetist. At this point in time, patients could have their surgery deferred because medically they were not at the point where they were able to proceed with surgery. Over the period that the OACCP program has been implemented, there's been more clients medically fit for surgery, which we can see on the graph here. So the column on the left that you can see is January to March in 2011, and the column on the right is the same period in 2012, and we've seen a 20% decrease in the pre-admission deferrals or cancellations due to those medical reasons of unfitness for surgery. One of the other important things that we've seen is that there's been an associated decrease in client complaints. So this graph here shows ministerial complaints, which are the blue line, and the total number of complaints. So that comes from the IM system that we have in New South Wales. And so we can see here that there's been a decrease in IMS complaints from 16 in 2009 to 5 in 2012. So that's the total number of complaints. We've also done satisfaction surveys with the ACI around how people feel about the program, and 98% of people have been satisfied or very satisfied with their participation in the program. Thank you.